usually turn off the lights. Yeah, so usually. Do you want this to be more facing the audience?
Well, I'm going to face it.
Okay. Okay.
This is all I need.
Yeah.
So I run it off again.
Yeah.
Take a charge this morning?
Well, I think that the whole light situation, it gets too dark.
You got one, sorry?
Yeah, some. Okay. Our University of Texas Police Department has a policy where they phone call all employees if there's security emergency. So weird. So it's 2 a.m. So they both have to operate near the hospital.
This graph is not getting too fast.
Okay. Actually, yeah.
Sure, absolutely. Do you need some more information?
I think we're all with one thing.
Yeah. So you just came from Texas?
Yesterday morning.
Oh, yes.
We've had surprisingly cold winter. We've had 2 rounds of snow. We go years without it. So it's been a very strange winter already. My immediate neighborhood was failed. But I had great faculty who had to move out of their houses. And institutionally, about 20% of our
Move out, not temporarily back.
well, one had to move. It was irretrievable. 20% of our employees either had major house damage or car loss. So actually, for several weeks afterwards, people couldn't get to work. And so I think the institution set up a very large charitable fund to provide grants to employees to help the company. It was a massive amount. We were poor. I knew our particular immediate area was had a good history of such things, but and my wife's brother, his family actually came and lived with us for 10 days because their house was in the area that was extremely at risk. Fortunately, we had an issue, but if about another foot worth, if we were at risk, we would have done things.
So, first like go and get into the actual real season.
I walk for the light. Some of the initial stuff.
I'm sure some of us, though, so.
Oh.
Yeah.
I'm sure you're gonna.
That's
Oh,
actually what that one at all.
what, because of, really that goes.
What's changed the thought process is much better capabilities. I was our call
So the many that this factor receives small degrees of all the terms Well, that's one of the key questions. It is. What's the that was a nice dinner.
Good.
So you can stay a little bit longer than you were? Yeah, my wife's planning for it. Yeah, it's gonna be getting started. Yeah. Probably go there. Now, I didn't go to the Statue of Liberty for years, so we finally decided to go to the Statue of Liberty. You live in a, like.
Oh.
Yes. That's right. I remember the nice to go. Poughkeepsie, they have this walking bridge that goes over the Hudson River. You know, a lot of people here.
Can I wait and sign in? Yeah.
You know you're on, Mama.
Yeah.
It's great, man.
So, Road and I had misfortune.
Still need some samples here.
Two of This was one.
Right after that.
Yeah, sure. There's lots of yeah, there's lots of.
Yeah, to prevent. Okay.
We've always had some.
Hey, Derek, how are you? Yeah, I come every once in a while to your conference.
I knew, yeah, New York University is where the licenses, it's always $50.
break typically as well.
Yeah.
That's
That's nice.
Yeah, no, so that's
Yeah,
ACA.
it's, you know, you can, yeah, he lives right in the town next to me, so we would see each other at the train stations. And not much once a month. Just to kind of catch up and see.
Easy.
Yeah, Mark's a very interesting place. It has basically good leadership because people that leadership, basically soaked up in all of the bronze. And, you know, we tend to think of bronze as in fact, incredibly diverse. Well, they are Southern Westchester. They're, I mean, they're natural, but I don't think anyone on Westchester. Actually, all these things really bad. I live in Westchester. Westchester Medical Center. Not just diabetes. All of the hospitals are kind of bad now. Memorial opened something in Paris. But like it's like a lot of memorial satellites. Most of the hospitals have presence, but not nobody found Wow. You don't see social research, especially in 1920. That was the way it is. Didn't even know about after that. Something they could do for them. Take it easy. I'm watching the Odd Couple. The ostramatics that have ulcers. What you do is eat milk. Hopefully progress will be at the same level.
Good morning, everybody. It's a pleasure to have Dr. Stephen Sherman here this morning. Steve graduated from Harvard and did his medical training at Johns Hopkins. It took him about 10 or 12 years to get over that.
Yes.
Stayed at Hopkins. And then has spent most of his career down there in Anderson. I think it's Texas down there. Just I got the place right this time. Introduced Jim Fagan from the wrong country. He never blamed me. So I've known Steve for many years. He's an international authority on thyroid cancer and thyroid cancer treatment. And in particular, he made big inroads into the use of recent drugs that mediate thyroid cancer. We don't have any cures yet, although you don't know. Judging by the title, maybe we're getting close. But it's a pleasure to have you here. Steve.
Thank you very much. And it's been about 20 years since the last time I had a chance to come up to a cyanide therapy patient. With some old friends and some new colleagues. What I thought I would do in the next few hours is talk about work that I and a lot of colleagues around the globe have been trying to do in trying to develop better ways of treating patients who don't respond to our standard traditional endocrine therapies for advanced thyroid cancer. These are my current recent disclosures. So briefly what I'll touch on, because I know it'll be a diverse audience, I hope, is a little quick review of our current therapies for advanced disease and really why they don't work. And then really spend the bulk of the hour talking about the therapies that have been developed and those that we're currently working on, the approaches. So as a brief reminder, thyroid cancer itself, the whole broad construct, is actually a relatively common malignancy. It's the 5th most common cancer being diagnosed in women in the U.S. That's been a fairly stable position for the last 5 or 7 years as 5th for women. The actual estimated incidence peaked at nearly about 60,000 a few years ago, and the latest numbers are showing a bit of a downward trend, and that may reflect perhaps response to recent efforts to deal with what's described as an epidemic of overdiagnosis. So still to be determined what the long-term direction is. But for perspective, when I was in training, the number was 12,000. So things have certainly changed. This is a worldwide trend, the increase in the disease globally. As you know, there are multiple histologies. Most of them fall into the category of differentiated thyroid cancer, which derives from the follicular cells and papillary follicular and Hürthle. There's the neuroendocrine medullary carcinoma, which incidence has been stable, in fact. It's the differentiated cancers that have been rising. And then the other end of the behavior spectrum is anaplastic cancer, which generally is thought to derive from dedifferentiation of papillary and follicular carcinomas. There's been some evidence that can arise de novo and debates on how that happens. But there's clearly this enormous spectrum of disease from indolent small papillary cancers that justifiably might not need to be diagnosed or treated versus anaplastic cancer, which is one of the most fulminantly growing malignancies that we have. And there turns out now, with increasing evidence, of a molecular evolution and a sequence of acquiring multiple genetic changes, mutational changes in the development of these diseases. So for follicular cell-derived
malignancies, we're able to identify, in most of them, specific oncogenic mutations that trigger the development of the initial malignancy, but one can evolve in a subset of patients to what's histologically called poorly differentiated thyroid cancer based on what it looks like under the microscope. But there's a broader array of tumors that I would say functionally are poorly differentiated. That is, having lost some or all of the functions that we think of as the normal differentiated functions of thyroid cells. That is the capacity to uptake iodine and incorporate it in an attempt to make thyroid hormone. And then finally, with the acquisition of additional mutational changes, anaplastic thyroid cancer is thought to arise from these earlier well-differentiated lesions. The neuroendocrine derivation is much shorter here and incomplete. So we point to point mutations in RET in developing medullary cancer. We also know that there's a subset that arise with RAS mutations and with some of the and some CDK mutations now being identified as well. Classically, when we see patients with differentiated thyroid cancer, when I was in training, this was the sequence. It was a fairly simple concept. Everybody pretty much got treated the same way. They had some extent of surgery, generally a total thyroidectomy. Most patients got radioactive iodine following that surgery, perhaps to prevent recurrence of disease in a subset of patients to treat metastatic or residual disease. And then lifelong TSH suppressive thyroid hormone therapy, because we didn't know whether we could stop such hormone treatment. And as time went on, that became progressively more aggressive, that treatment, because our target of suppressing TSH kept changing as our assays improved. So we probably progressively made patients more thyrotoxic as the decades went by, thinking that we had to bludgeon TSH down to undetectable, regardless of what the definition of undetectable was. And we thought this worked for most people. Radioactive iodine is certainly not a new treatment to us, but I would say it's the original targeted therapy, based on this original report in the distinguished scientific journal Life magazine, for those who remember Life magazine. And this was a report of the very first individual ever treated with radioiodine for metastatic thyroid cancer. But more importantly, this was reported as the first person ever cured of a metastatic cancer. In this case, by treatment with 4 doses of radioactive iodine. And this cachectic man here actually is not necessarily because of the cachexia from his cancer, but he had a follicular cancer that was making him thyrotoxic. It was a very, very well-differentiated follicular carcinoma, very avid. And in those days, they were using radioiodine already to treat thyrotoxicosis. And that was the intent here, but it turned out to be an effective treatment for his malignancy until, I believe, he subsequently died from leukemia. And these are the kinds of patients that we can treat and cure, so we believe, with radioactive iodine, with diffuse micronodular metastatic disease throughout the lungs. This is a patient with a normal chest X-ray, with a normal CAT scan of the chest. All other imaging modalities are negative, but functional imaging with radioactive iodine will identify diffuse widespread disease. And this young individual is somebody that today we would treat with high-dose therapy, and the evidence is that we can cure. Now, as endocrinologists, radioactive iodine was the one thing that we could do in treating metastatic disease. And our surgical colleagues could treat with surgery, and we could use radioiodine. And so we had a very limited quiver. We had very limited tools that we could use. And so what happens when those tools don't work? We use them again. And so the classic model, if a patient had recurrence or our treatments were unsuccessful, was to go back and keep doing it again and again. And patients repeatedly were treated with radioactive iodine, long beyond there being evidence of response to the treatment. But because we could see it on a scan, we felt that there was some functional benefit from treating. So this was really the traditional model for recurrent and metastatic disease, repeated treatment with the only tool that we had. But it's long been recognized that radioactive iodine uptake is heterogeneous. At a macro level, that could be that you see it in some lesions on a scan but not in others. But even microscopically, radioiodine uptake in so-called avid and responsive lesions is in fact heterogeneous. And in the old days, some poor surgeon in Boston had to take care of this patient because this is a patient with mediastinal recurrence of follicular carcinoma, and he was going to surgery, or she was going to surgery. This is the H&E in black and white, unfortunately, of the resected tumor. But this patient had been treated with therapeutic radioiodine a few days before going to surgery. And so this shows you at a macro level the radioiodine uptake in that tumor. And you can see in the northern area, there's good uptake, but in the southern area, it's really quite absent. And the functional impact is in the superior component. It's necrotic. And down here, you still see very well-functioning, normal-looking follicles consistent with the malignancy. So radioiodine uptake can be very heterogeneous within a tumor lesion, and even cell to cell can be quite heterogeneous. And it was recognized, in the 1950s, soon after patients started getting treated, that it did not always work. One of the very first basic scientists at MD Anderson, Jack Trunnell, was studying iodine, the acquisition of iodine incorporation in chick embryos, because the results of therapy with thyroid cancer with radioactive iodine have been disappointing. And they wanted to understand the biology of iodine uptake and why it developed normally and why it was lost. Something that, decades later, we're still trying to figure out. So on a schematic basis, we can define radioactive iodine refractory disease in multiple ways. We can have a patient like this who has multiple lesions that show no uptake whatsoever on an iodine scan. And that's probably the easiest conceptually for us. And traditionally, we've thought of those as radioiodine refractory. We have, patient number 2 here who's got multiple lesions, many of which do take up iodine. But the lesions that are going to get that patient into trouble are more likely to be the ones that don't. That's the leading edge of the disease. And historically, if we based our definition of disease extent on radioactive iodine imaging, we didn't necessarily know about these lesions here. We weren't doing tomographic and cross-sectional imaging, structural imaging. It was all functional. So we didn't necessarily know about a lot of those lesions that ended up resulting in morbidity until much later. And then finally, and this is in some ways the most controversial within endocrinology, but fits a classic oncologic thought process, and that is we have patients who have what looks like excellent uptake on radioiodine scans, and yet despite giving them therapeutic radioactive iodine, the lesions grow within 6 to 12 months. Our therapy is ineffective no matter what our scans look like. And so these patients are failing, have really disease that's resistant to our treatment. Now, yes, we want to make sure that they've had, low iodine diet and with dosimetry that we're delivering enough iodine, we think, but there's a lot of factors beyond the delivery of iodine and the retention of iodine that lead to whether this tumor is actually going to respond to the iodine. So we see different patterns of refractory disease, but the end result is that these are patients who are going to get into trouble or die from their metastatic disease. So the American Thyroid Association, in its last update to differentiate carcinoma guidelines, have now given us some ways of defining what radioiodine refractory disease is, never any uptake on a post-therapy scan, or loss of what had been avid uptake, uptake that's heterogeneous in some but not all lesions, and then tumors that progress despite iodine. And what's interesting, it just shows already how dated our guidelines are, is there's a pretty definitive statement at the end of this paragraph defining refractory disease, which I thought was really important. It was a message we really wanted to deliver, which is that radioactive iodine therapy is not indicated in patients who have refractory disease. Now, never indicated is a little bit of a strong statement, however, and I think that we were not considering what is evolving as a thought process, and for which we now have some data, on the ability to redifferentiate tumors and perhaps restore the ability to respond to iodine. So I suspect in the next update, whenever that is, and I sure hope I'm not on the committee by that time, because I've spent the last 20 years doing guidelines, but I think that that will emerge into the next version. So how do we evaluate these patients? It's very important that we get appropriate and standardized cross-sectional imaging so that we can understand the extent of disease. As I explained to patients, we need to know what's where, we need to know what's changing, what's the pace of change, and what are the areas that we need to focus on. So serial imaging, lesion growth rates are very important in our ability to, right now, to prognosticate and balance the burden of disease with the rate of progression. We have many patients with widespread disease who are really asymptomatic and stable oftentimes for years. And with our current technology, we still don't have a curative intervention. Those patients do pretty well without doing much of anything. We need to understand the risk of their progression and assess what could go wrong. That lesion in the hip or that lesion in the vertebral spine, is something that we may be a little bit less willing to leave alone than that 1.5 centimeter lung lesion, because they could get into trouble with a little bit of growth of tumor. So what's the risk of unchecked growth of disease, and what's the risk of the therapy? Because every intervention that we have carries some risk, carries some cost, both theoretically and financially. So the ATA gives us some idea of what we should do to treat and consider, for example, where there are localized or focal therapies that can be of benefit with radiation, with surgical intervention, ablative techniques, radiofrequency ablation, cryoablation, etc. The role of TSH suppressive hormone therapy. Patients who are progressing, we recommend, of course, consider clinical trials. Being academics, we always put that as the first thing that we're thinking about. But in standard clinical practice, what has emerged is the use of various types of kinase inhibitors, which we'll review. But let's not forget the value of TSH suppression, and also how much TSH suppression is needed. This comes from a non-prospective study. This is a non-randomized trial, but a cohort study of multi-institution registry that we published a few years back. This was a program that was started by Harry Maxon in the 1980s. But what we did was we took the subset of patients who had distant metastatic disease from the time of diagnosis of their metastases, whether it was an initial presentation or 5 or 10 years down the road. And we said, what was their survival as a function of their level of TSH suppression over time? This was a methodology developed by David Cooper. And there are three levels of aggressiveness of TSH suppression therapy. And green and yellow represent the most aggressive and moderate levels of suppression, which functionally work out to TSH levels that average over time being at the low end of normal or below. Those survival curves are really indistinguishable. We saw no evidence, even in patients with the greatest extent of disease, with metastatic cancer, we saw no evidence that survival was enhanced by bludgeoning TSHs down to undetectable levels. As long as it was below normal, it seemed to maximize the survival benefit. The patients who did worse were those where TSH levels were not suppressed, which were on averaging basically towards the upper end or above the reference range. So high TSHs are bad, but the lowest levels of TSH are not necessarily bad. They're important, a little bit more conservative approach than we've traditionally thought of. But still an important and effective therapy. But what we're now focusing on is really trying to get into the biology of the tumor cell and its microenvironment, the world around it, and how we might manipulate the growth factors and the signaling pathways within the tumor cell and within the microenvironment that facilitate or allow growth and progression of disease. There's been a lot of focus on the canonical MAP kinase signaling pathway, which appears to be central, certainly in oncogenesis of both differentiated as well as medullary carcinoma, and then some of the other signaling pathways as well. BRAF and RAS mutations are the most common that are found in differentiated carcinoma. We know from the TCGA that really, even though these two kinases sit right next to each other in the MAP kinase signaling pathway, mutations in one or the other really creates a different biologic profile of disease. And so we can now define what are BRAF-like tumors and RAS-like tumors. They have different functional effects in terms of things like differentiation status, methylation patterns, expression patterns, and also radioiodine uptake, which is very different across this spectrum. As we evolve from differentiated into the poorly differentiated nanoplastic, we see an acquisition of additional mutations. So these are different genes along the way. As we progress down the spectrum, we add additional ones that appear to associate or yield a more aggressive disease, such as TERT promoter mutations and P53 mutations. And these are similar to those that are seen with other solid tumors as well, with similar functional impact. So what we have, both now approved as well as in clinical trial, we have drugs that can target many of the kinases that are in these different signaling pathways. And we have focused a lot on a class of drugs here that we collectively call anti-angiogenic because they target vascular endothelial growth factor receptors in the microenvironment. But most of these drugs also, as it turns out, target RET. And just as a point of history, RET PTC fusion mutations were amongst the very first mutations identified in differentiated carcinoma. And when we first got into this game of trying to identify whether we could use kinase inhibitors to treat thyroid cancer, it was before BRAF had even been discovered. And we did not really understand the spectrum of mutations that led to disease. RET PTC was only known in thyroid cancer, and we thought that that was probably the most important mutation there was. And when these drugs, some of the early kinase inhibitors, anti-angiogenic drugs, were being developed, we noticed back in the online appendix to the papers that these drugs that were being developed to target VEGFR also targeted RET, RET PTC. And so we started enrolling patients in clinical trials at our institution and others, thinking mistakenly that they could benefit because they had RET PTC mutations, and we could be targeting that with these drugs. It turned out in those very earliest trials that when we tested, about 1% of the patients had RET PTC mutations. And probably the main reason why we were seeing some benefit was because of the VEGFR activity. So our hypothesis that they could be helpful was correct, but for all the wrong reasons. But if we frame shift quickly to where we are now, there are two drugs that are FDA approved on the basis of randomized phase 3 clinical trials. Sorafenib was the first one, and lenvatinib. Sorafenib is primarily a VEGFR antagonist with some weak BRAF inhibitor activity and several other angiogenic kinases that inhibits, but primarily for VEGFR activity. And in this phase 3 trial, we saw that there was about a 5-month improvement in the progression-free survival. That is, the rate in which patients had clinically significant progression of metastatic lesions. So a delay in progression was identified. Lenvatinib, which is also a very potent VEGFR antagonist, but also an FGFR antagonist, meaning that we think that FGFR plays a role in the resistance to VEGFR antagonism. So we kind of had a double hit on angiogenesis by using lenvatinib, and it had a considerably longer improvement in progression-free survival of over a year, and also with lenvatinib have the greatest degree of tumor shrinkage. So within 2 months, you can see patients who have 30, 40, or 50% reduction in tumor diameter with lenvatinib. With sorafenib, it's a much more delayed response that's seen, and to a lesser degree. So lenvatinib is clearly a much more potent agent, and in our hands, it's usually a drug of choice that we start patients with who require anti-angiogenic TKIs. But eventually, almost all patients come off of the drug. For some of them, it's because of side effects, but many of them it's because eventually they progress on their first-line therapy. And we now have a published trial of second or third-line TKI using a different drug, cabozantinib, but coming back to the same quiver, in a sense, of anti-angiogenic agents. And in this single-arm study, showing about a 40% response rate in patients who had failed a previous anti-angiogenic agent. This is probably going to move into a phase 3 trial soon. But the principle here being that we can use and reuse these agents in patients. I have one lady who has been on one anti-angiogenic agent or another for the last 12 years. she has had over the long trajectory gradual progression of disease. But we keep on being able to introduce a new stop period for her by switching her from drug A to drug B to drug C. Not necessarily very satisfying intellectually. We don't quite understand why this pattern may work or when it doesn't, though. And a very important question is, does this improve survival? We know that we can halt tumor growth, but we often see patients when the disease comes back, it comes back quite aggressively, perhaps with skeletal and brain metastases. And so in those two phase 3 trials, the data does not really indicate a significant improvement in overall survival yet. Now, some of that may be the design of the study, because they allowed crossover in these placebo-controlled trials. And with lenvatinib, if you do statistical manipulation to try to account for the crossover effect from placebo to active agent, you may be able to tease out a survival benefit, but it's certainly not grossly obvious to us. That's a very important caveat. So as Terry introduced, we're certainly not curing people with these agents. We think that we're slowing the progression of disease. We're not sure that we're helping people live longer. And living longer and living better are both of the goals. In medullary cancer, we have a similar story. Now here, of course, these agents that target RET, we think, might be beneficial because RET is important in about half of medullary cancers, both sporadic and inherited. Vandetanib was the first of these agents, again with improved progression-free survival. And cabozantinib, similar story with lenvatinib, appears to be more potent as both VEGFR and RET inhibitor, and a larger degree of benefit or of improvement in progression-free survival that's identified. But with cabozantinib, we at least have the first time evidence that there's a subgroup of patients who experience improved survival. And over here, because it's not a pre-planned analysis, so I keep the figure small, it's somewhat ad hoc, post hoc. But patients who have a RET918 mutation, which is the most common RET mutation that's seen in sporadic medullary cancer, had about a 2-year improved overall survival when treated with cabozantinib compared with placebo. And so we at least now have some basis to say that we can help patients live longer with these agents. But I'm not sure we can say that they live better. And the side effects are quite significant, and there are often patients who stop because the side effects are really intolerable. Some of them, that we treat aggressively is hypertension. Diarrhea and abdominal cramps and pain are very, very common problems. Cachexia is something that we are seeing with the more potent VEGFR antagonists, cabozantinib and lenvatinib in particular. And as we treat patients for 1, 2, 3 years, we see 25% body weight loss, and for not good reason. We don't understand what it is yet, and we have some studies looking at it. The cutaneous manifestations are problematic for a lot of patients, especially those who stand on their feet all day, and actually the effect of pressure appears to exacerbate the anti-angiogenic toxicities in hands and feet. The people who have the worst problems with their fingers are those who are keyboard operators and typists. So these can be very dose-limiting or reasons to stop, and some of them are life-threatening. And of particular interest for our thyroid patients are tracheoesophageal fistulas that we see. For those patients who have disease that's still wedged between the trachea and the esophagus, or who've had radiation therapy, this can be a very dangerous and lethal complication of anti-angiogenic therapy. We are using less radiation treatment, in part because we want to save those patients the ability to use anti-angiogenic agents at a later time. But also with some caveats, as we'll see, that there are patients for whom simply these treatments are not appropriate and would be too dangerous. So let's go back then and say, what do we know about the biology of this disease that might allow us to target some other therapies beyond the existing approved therapies that we now have for cancer? And remember, 60% of differentiated or papillary carcinomas have an oncogenic BRAF mutation, usually V600E, analogous to what's seen in melanoma. And BRAF inhibitors were developed for treatment in melanoma. When Vemurafenib was in a phase 1 trial at our institution, they were focusing on melanoma, but we managed to get 3 patients with papillary cancer and BRAF mutations into that trial, and one of the 3 patients had a response. And that led to a phase 2 study which was published a number of years ago in Lancet Oncology, and we see about a 25 to 35% response rate in those patients, higher if they had no prior treatment with sorafenib. Dabrafenib, another BRAF inhibitor, similar story, about a 30% response rate that's achievable. And these agents have a different side effect profile and may be appropriate for different patients. We've learned in melanoma that in addition to BRAF inhibition, if you combine it with a MEK inhibitor, next step down on the pathway, we seem to get higher response rates and, somewhat paradoxically, a lower side effect profile. That the combination of Dabrafenib and Trametinib leads to better outcome, and that's become a standard treatment for BRAF mutant melanoma. But thyroid cancer is not melanoma. We keep having to relearn that lesson. And in this randomized trial that was presented at ASCO last year, we showed that, in fact, there was no difference in outcome, Dabrafenib versus Dabrafenib and Trametinib in combination. And the side effect profile was no different as well. So this is a little different than the experience in melanoma. But both of these approaches are effective, and in fact, we often sequence them. Since there does not appear to be an advantage to starting the Trametinib earlier, we may, treat a patient with a BRAF inhibitor to start, and then consider adding the MEK inhibitor at a later time if they begin to progress on BRAF alone. But this concept of doing BRAF inhibition can also be extended to other settings beyond just the patient who has progressive metastatic disease. We often come across patients who have very locally advanced disease in the neck, and our surgical colleagues will tell us this is going to be a difficult operation, or this is an unresectable tumor. And if we can shrink these tumors when they're in the lungs or in lymph nodes in the neck, can we shrink them and facilitate surgery for recurrent or advanced disease in the neck? So that led my colleague Maria Cabanillas to do a neoadjuvant therapy trial that was presented at the European meetings last year. There's a single center study with patients with locally advanced BRAF mutant papillary carcinoma. Generally, most of these patients were considered to have unresectable disease. And if our surgeons tell us it was unresectable, it's a pretty bad situation. But they got 8 weeks of Vemurafenib, and actually, for the scientists in the audience, the primary endpoint of this study was translational. It was to get tissue to look at the effect of BRAF inhibition on papillary cancer in humans, and those analyses are still ongoing. But the secondary outcome was to look at the clinical benefit of doing this, and so patients were imaged and then potentially go to surgery. And so 14 patients were able to be restaged after 8 weeks of therapy, and this is the response curve, pretty similar to what we were seeing in metastatic disease in terms of response, or at least patients getting some degree of tumor shrinkage. But importantly, for many of them, they were now able to go to surgery. And these are the outcomes of their surgery here. And with a great number of these patients, they were able to end up without any microscopic evidence of residual disease from at the time of surgery, or a microscopic positive margin, R0 or R1 resection. So we think that this is a concept that we can move into our routine care pattern for patients with locally advanced disease, is to hold off on the surgery if they have a BRAF mutation and try to use one of these inhibitors for 2 or 3 months to enhance their ability to go to the OR. And the ultimate in patients with advanced and radioiodine unresponsive disease is anaplastic cancer. It turns out about 40 to 50% of anaplastics harbor BRAF mutations. We've realized that these actually are extremely sensitive to BRAF and MEK inhibition, at least early on. And these are some stories that we published a couple of years ago. One of the first patients we had with very locally advanced anaplastic cancer and metastases, and you see progressive shrinkage of the disease with combination therapy with Dabrafenib and Trametinib, a BRAF and MEK inhibitor. And on the basis of these early observations, there was a trial to look at this combination in anaplastic cancer. This was a so-called basket study, so this was part of a very large study that was sponsored that had different subgroups for different diseases. But one of the baskets was specifically for anaplastic cancer. And we contributed the most patients to that particular basket study. And this was really quite striking. We had a 70% response rate in anaplastic cancer, meaning 70% of the patients had tumor shrinkage of 30% or more on therapy without the appearance of new lesions, their best overall response. After 12 months, 90% of these patients were still responding to the therapy. And to 12 months, 90% of patients in this trial were still alive. Really a remarkable change for anaplastic cancer, where the median survival historically is thought of as 3 to 4 months. Now, there actually are some data that prior to the advent of targeted therapy, the survival of anaplastic patients has been slowly tickling upwards, kind of getting up to 5 months. But still, for our world, a fulminant and highly lethal disease. But this was the first hint that there may be a therapeutic initial path for these patients. This was just published last month in the Journal of Clinical Oncology.
Patients were selected for BRAF mutations?
Yes, these all had BRAF mutations.
And the rate of BRAF mutations in ATC?
About 40 to 50%. What we do is we send, we either get immunohistochemistry, but that can be somewhat tricky in these patients because they have so much infiltration in the tumors. And we send off for BRAF circulating DNA and get that back in a few days. And time is of the essence. And so actually, in our institution, what we now do is we will give a bridging dose of paclitaxel first while we're waiting for the BRAF status to come back. We'll see how we work that into a trial. It turns out that there are several agents, including anti-angiogenics, that may have some benefit in anaplastic. Lenvatinib was reported in a cohort of Japanese patients having a fairly high response rate. There is an international phase 2 study in anaplastic cancer. Results are not available yet, but recruitment has been halted for the interim analysis. But we have seen patients, who do acquire a partial response when treated with a potent anti-angiogenic as well. But obviously, there's a long way to go for anaplastic as these patients do eventually progress. Again, coming back to differentiated cancer, there's a number of other targetable mutations that we see, and in particular, some of the fusion mutations are really quite interesting. And we're seeing these in other cancers as well. We're learning, of course, from our oncology colleagues. If you think about a BRAF mutation or you think about a RET mutation in medullary cancer, these are mutations that occur in genes that are normally expressed in the context of that cell. BRAF activity belongs to some degree in a normal follicular cell, and RET is a normal constituent of a C cell. But these fusions lead to genes being expressed in locations where they don't belong. So we don't think of RET signaling as being active in normal follicular cells, but a RET-PTC fusion brings a promoter that's expressed in the follicular cell upstream from RET, and now suddenly RET appears where there's no natural constituency for it. And these sorts of fusion mutations, we're beginning to think may be particularly sensitive to our targeted therapies because we're treating things that don't belong in that context. And what's evolved with TRAC mutations is a really good example of this. So this is another type of tyrosine kinase that's important in neural development. And TRAC fusion genes are seen in a smattering of different types of solid cancers. Some of them are very rare cancers, or it can be uncommon in more common types of cancers. And there may be a few thousand people each year who have TRAC fusion mutations with different types of cancers. About 1 or 2% of papillary cancers have TRAC fusion mutations in them. And drugs have been developed from several companies that are highly selective inhibitors of these fusion TRAC genes. And one of them, larotrectinib, was a series of phase 1 and phase 2 studies where they combined the data across these different studies to give us information that's really quite interesting. Histology independent, regardless of the type of tumor that's seen, roughly the response rate is about 70%. And these responses are quite durable. In 5 patients, 4 who had papillary cancer with TRAC mutations, 4 of them responded to the drug, so 80%, very small sample. But what we've seen with some of these other tumors is, in fact, complete responses are possible and quite durable. This is likely a drug that will get approved in 2018 for any solid tumor that has a TRAC mutation, putting some value on testing to see if such a mutation is present in the tumor. RET, we used to think, was R mutation, right? That was thyroid, papillary, and medullary, had the different RET mutations. But, you know, our world is swamped by other cancers that we now understand express RET mutations. Non-small cell lung cancer, about 2%. Fortunately for us, there are far more patients with lung cancer and RET mutations than there are thyroid cancer patients with RET mutations. So a lot more interest in the pharmaceutical industry for developing drugs that target RET. And there are multiple ones. And let's step back and put this in context, why this is important to think about. So cabo, lenvatinib, and vandetanib are our three primary anti-angiogenic agents that we have, right? They target RET with different inhibitory components, but they're much more anti-angiogenic, far more potent as VEGFR2 inhibitors. And you can calculate the ratio of inhibition, RET to VEGFR2. And so you see that these are predominantly VEGFR inhibitors. But there are three agents in phase 1 trials, LU667, LOXO292, and RxDX105, where the ratio is far in favor of being RET selective. Not purely RET inhibitors, though, and so at very high doses, we're beginning to see some anti-angiogenic side effects. But these are much more selective for RET, and that has some interest, some value. This is an example of a patient with medullary cancer who has a RET mutation and has carotid encasement. This is a patient that we would not treat with cabozantinib or vandetanib because of the potential toxicity of a carotid blowout from using an anti-angiogenic drug when tumor is completely encasing the carotid. And yet, we're seeing rapid responses to a highly selective RET inhibitor. You can see the biomarkers here improving very quickly. And patients clinically feeling better. Unlike using anti-angiogenics, the diarrhea gets better when we treat them with a RET inhibitor and not worse. So there may be a very important role emerging. Watch over the next year or two for the results of these phase 1 trials to come out and moving some or more into phase 2 or directly into phase 3. Now, if we move away from the world of kinase inhibitors and say, what else is being developed in oncology that might apply to thyroid cancer? And of course, the buzzword these days, whether it's Time Magazine or Science Magazine, is immunotherapy. At my institution, we stole Jim Allison from Memorial Sloan Kettering, and we're waiting for him to get his Nobel Prize for discovering the importance of some of the checkpoints and the use of checkpoint inhibitors to unmask tumor and allow a patient's own immune system to react against and attack a patient's cancer. And this became, extremely popular as a concept. I would like to remind us of what's called the Gartner hype cycle, that I think in medicine we observe over and over again, especially with the public media, which is we get a new brilliant idea, we run into this peak of inflated expectations where we think this is the next best thing to apple pie. We go through the trough of disillusionment when we discover all the realities of both ineffectiveness or partial effectiveness and toxicity, the slope of enlightenment, and then finally some plateau of productivity where we realize the appropriate use of this new innovation. And I think that we're somewhere, here in this slope of enlightenment right now with immunotherapy. So where it works and when it works, it's really a tremendous innovation. And what we've realized is that there's a spectrum of tumors in terms of how they will respond to immunotherapy and the ability of the immune system to react to neoantigens that the tumor might express. And those neoantigens are often a product of mutations. Tumors with a higher mutational burden seem to often be better targets for immunotherapy because there's a lot more for the immune system to say, hey, this is foreign, this doesn't belong here. And so we can actually look at the spectrum of mutation density or the amount of mutations, and those that are over here turn out to be responding quite well to immunotherapy. And those that are down here doesn't seem to do much good. And sure enough, from the TCGA, this is where papillary thyroid cancer fits, down to the spectrum where we would not anticipate that immunotherapy with checkpoint inhibitors wouldn't necessarily be an effective intervention. And there's clinical trial data to support that conclusion. So this was pembrolizumab, an anti-PD-L1 agent. And in this keynote study, there was a subgroup of patients with papillary cancer, advanced radioiodine refractory, just who you'd want to have a novel therapy for. There's a pretty disappointing response rate of only 9% to a single agent therapy. And such low response rates are seen with a lot of other solid tumors as well, that all kind of fit this spectrum of not being great candidates necessarily. Now, there is some evidence, though, that perhaps we can queue up these tumors and make them more responsive, make them better candidates by combining agents that enhance the immunogenicity of the tumors. There's some evidence with use of anti-angiogenic agents. And our Thyroid Cancer Consortium, ITOG, International Thyroid Oncology Group, has just activated a randomized, trial, not randomized, of patients to combine that drug pembrolizumab with lenvatinib. And there's some preclinical support for this concept. We'll see how that works. We have seen patients who have had exceptional or remarkable results, though, that even single agents. This was a patient reported treated with nivolumab, another agent with anaplastic cancer, and really a remarkable resolution. Now, it turns out that there may be rationale for it. Unlike papillary cancer, anaplastic really is an ideal microenvironment for immunotherapy. This is from Ramona Dadu, who's an assistant professor in our group, and she's been studying the immune profiles of different thyroid cancer subtypes. And anaplastic really strikes one as an ideal target for this type of therapy. Extremely high expression of different markers within the tumor that reflects what we see grossly, which is that there's often a very high immune infiltrate into the tumor. But all of the predictors one would expect that this disease would respond. And there is preclinical evidence to suggest that these tumors might respond. This is work from Suri Karengi's group up in Boston, where they had an animal model of a BRAF mutant anaplastic cancer grown in an immunocompetent mouse, treated with either a BRAF inhibitor, an anti-PD-L1 agent, or the combination. And you see that the combination was really quite potently beneficial for the mouse growing this tumor, to suggest that combining BRAF inhibition and a checkpoint inhibitor could be a particularly effective approach. Now, a number of years ago, we decided that we wanted to be masochists at Anderson, and we put together a quality improvement project to try to figure out what were the obstacles to getting patients with anaplastic cancer in our front door. And as a result of that, we tripled the number of patients that we've seen. So we get about 60 to 70 a year with newly diagnosed anaplastic cancer. About 40 to 50% go on clinical trials. So we now actually have the capability to do single institution phase 2 trials in this disease. So one that has been launched last fall is this study looking at patients with anaplastic cancer and using mutational directed therapy approach to assignment to a specific cohort. So as I mentioned before, while we're waiting for their mutation profile to come back, these patients often will progress and perhaps become untreatable. So we start out with a dose of a taxane to begin with, using Abraxane to get a single dose of that, and that buys us a week or two until we can get their mutation data. If they have a BRAF inhibition, they're assigned to a cohort where they get an anti-PD-L1 agent from atezolizumab, combined with the BRAF inhibitor Vemurafenib and MEK inhibitor Cobimetinib. So we're hitting them with a triple regimen. If they don't have BRAF, but they have a RAS mutation, or for some reason have a contraindication of BRAF, then they get just the MEK inhibitor and the immunotherapy. If they have neither BRAF nor RAS, or are not eligible otherwise, we're combining them with bevacizumab, anti-angiogenic agent, and atezolizumab. And then finally, there are patients who fail and end up in cohort 4, not candidates for any of the other 3 targeted agents, and they're just getting the combination of paclitaxel and atezolizumab. This is a study that's part of a rare tumor alliance that we have with Genentech, that they're fully supporting both for the clinical trial for all of the molecular correlates that are deriving from it. And this has been recruiting ahead of schedule. So we expect that probably by the end of this year, the clinical trial aspect will be fully enrolled. But as endocrinologists, we still use and like radioactive iodine, and I want to close by talking about some fascinating data that suggests that we can come back and use radioactive iodine in patients where we've had to stop using it. What our friends at Memorial and others elsewhere have come to realize is that BRAF not only defines a molecular genotype of disease, but also there's an important functional impact. And activating BRAF mutations in thyroid cells leads to the loss of radioiodine uptake. There may be other factors as well, but in this mouse model that Jim Fakin's group had, this shows you radioiodine being incorporated into this transgenic mouse that's expressing BRAF wild type. But when they turn on the V600E mutation, iodine uptake is essentially lost. And then when they turn off the mutant BRAF, iodine uptake is mostly restored. So showing the importance of the switch effect of a BRAF mutation. But if we do this not by turning on or off the gene, but by using a pharmacologic inhibitor of either BRAF or MEK, what Fakin's group showed was that you could largely restore iodine uptake pharmacologically in this mouse model, which led them to do a very elegant clinical trial where they used the MEK inhibitor Trametinib, and I'm sure Jim has been here and shared these data. That was published in the New England Journal. But you can see here in this I-124 PET scan, baseline before and then after 5 weeks of Trametinib, remarkable restoration of iodine uptake. You can see it in the two-dimensional, the fusion imaging, and here showing not just in lungs, but skull lesions that now have iodine uptake restored. In that trial, they studied 20 patients with refractory disease. They were given 5 weeks of the MEK inhibitor and had an I-124 PET scan. And if dosimetry predicted that they had sufficient restoration of iodine uptake, they could go on to treat them with a high dose of iodine. And so 60% of the patients had iodine uptake sufficient to predict responsiveness so they could be treated. At the end of the day, 5 of the 25 patients had partial response, meaning significant tumor reduction. So on an intent to treat analysis, it's about a 25% response rate of patients who go into this sequence seem to benefit. And some suggestion that the presence of a RAS mutation might be predictive of benefit. That has led to a lot of studies looking at this using the BRAF inhibitor Dabrafenib, a far less elegantly designed trial that didn't use dosimetry, but limited to patients with BRAF mutations, but pretty much the same kind of response, only about a 20% response rate. We can restore uptake, but not necessarily get real therapeutic benefit from it. Now, in our institution, we haven't been doing this in a trial, but we've been treating a lot of patients with BRAF and MEK inhibitors. And so if we can get them away from iodinated contrast for their CAT scans for a few months, we can ask the question, do an iodine scan and see if we can treat them. And so we've had an informal approach to looking at redifferentiation, and these are some of the patient experiences. You can point to somebody like this who has remarkable uptake that's restored after several months of BRAF inhibitor therapy. To the degree, in fact, that this patient, when treated with iodine, developed radiation pneumonitis. You really have to be very careful because this can be an extremely potent thing to do. These are the response data that we get. This was the response to kinase inhibitor therapy before radioiodine, so not much response, but stable. This was the response after giving them radioiodine. So you can see that there was a lot of tumor shrinkage that came from the radioactive iodine. Importantly, though, when we gave them the iodine, we stopped their kinase inhibitor therapy. So we took them off. And this is what happened. These patients were often stabilized by the radioiodine. So the sequence of kinase inhibitor followed by radioiodine allowed us to stop the expensive and toxic kinase inhibitor in the majority of these patients. And they could be stable at this point, the duration of follow-up, about 14 months without further systemic therapy. So we may not get that much benefit from redifferentiation and more iodine in terms of tumor shrinkage, but it may allow us to have patients come off of kinase therapy, save them the toxicity, and save them the $10,000 to $15,000 a month. That's the cost of these interventions. So trying to figure out what's the role. There's also some novel understanding of the mechanisms of resistance, and Fagan's group also identifying this important pathway that triggers primary resistance to BRAF inhibition mediated through the HER3 receptor. And there's preclinical evidence that adding a HER3 inhibitor to this BRAF-MEK combination might provide further augmentation of the benefit of iodine uptake. So as we dissect out the mechanisms by which iodine uptake is lost, we may actually be able to find ways to come back to this very thyroid-specific intervention for clinical benefit. So if this is where we started when I was early in my career, I think this is where we are now. We've turned iodine into a much more potent hammer, but it's still just a hammer. And there's a lot of more work that we need to do. In our institution, this is now our algorithm for how we approach these patients with radioiodine refractory disease. We start with mutation profiling. We allocate therapy based upon the presence of BRAF mutations or rare fusion mutations, and then decide on the therapeutic approach, which often ends up in a clinical trial, often ends up with non-standard therapy for this disease. And if they're on BRAF or MEK inhibition, considered if we could sneak in some radioactive iodine as well. So this is something that a lot of the data that I presented to you that we've been involved in is actually done by endocrinologists in our institution. So in my department, we have 13 clinical endocrinologists, 10 of whom are using kinase inhibitors and 4 are using checkpoint inhibitors in the treatment of advanced thyroid cancer. And so we have had an opportunity to develop real expertise in oncologic endocrinology and moving therapy beyond what endocrinologists traditionally provide. And now we're trying to teach others to do what we're doing. So we developed an advanced fellowship program a few years ago. We're taking applicants for the 5th year of this program now, institutionally funded. 2 of the 3 previous graduates of the program are in academic positions here in the US, and a third is in Europe. And if you have fellows, or for the fellows in the audience who think this might be an exciting career path, come to Houston for a year, and we'll teach you how to do what we're doing. And Dr. Hu, our deputy chair in the department, would be glad to hear from you. I have a lot of people to thank. Colleagues at Anderson who are all part of our thyroid program. Those in asterisks have been endocrine fellows who have worked on some of this research and put a lot of it together. We have a very tight collaborative relationship with the Investigational Cancer Therapeutics Department, which is a phase 1 program. We have at any one time about 100 different phase 1 trials active at MD Anderson, most of them mutationally selected. And they've been very receptive to having endocrine patients. And this model of what I've shown you for thyroid cancer, we're now replicating with malignant pheochromocytoma, with adrenocortical carcinoma, and our next step is in parathyroid cancer. So we're trying to do this in multiple endocrine malignancies. And then finally, some of the work has been with a fantastic group of colleagues in ITOG through our National Thyroid Cancer Consortium. And then finally, some of it has been funded by a joint SPORE grant between Ohio State and MD Anderson. Thank you for your attention. Whatever time remaining, whatever questions folks have. Ross, please.
I'm just curious, is mutation testing of the tumors available outside of your institution?
Yeah. So it's something that there's a number of companies that do mutation profiling, are best known as Foundation Medicine. And Foundation's advantage is that they do the fusion genes. The disadvantage is that they don't use germline. They use an algorithm to try to calculate what mutations they find would be a germline versus a somatic mutation. Sometimes that can be a little tricky. But that's one of the standards right there that can often be sent to. We also use the circulating DNA profiling. We've developed some in-house assays for that, actually, which is a whole other fascinating story. But a company called Guardant, which is headed up by Rick Landman, who's doing Veracyte, has really made a huge dent in that field. There's a number of ways that you can quickly identify. And finally, BRAF immunohistochemistry is a pretty good technique as well for a quick and dirty assessment. Thank you.
You didn't discuss the change in the mutations in metastases. So when you treat the patient, you're going to get recurrence. That's cancer.
Yeah.
And then you want to identify what's in the recurrence. How much data?
Unfortunately, no. We don't do a lot of repeat biopsies as kind of a standard way. Some of our trials are now incorporating that. In this, trial with anaplastic cancer and combination therapy, that's actually written into it. So all of those patients are actually getting serial tissue collections. There's not a whole lot of data really about the subsequent acquisition in papillary. We have recently reported in medullary because of our ability to develop a blood assay for the REC804 gatekeeper mutation. We're now able to show that we're seeing the emergence of gatekeeper mutations in patients treated with Vemurafenib for medullary cancer who have, say, a 918 underlying. So these, additional mutations certainly do occur. We just have not focused on them very much yet. I think that's the next important step. And let me just say, we have had some patients, and there are preclinical models that support this, with long-term BRAF inhibition. We've seen the acquisition of RAS as a secondary mutation. We've also recently seen a different kinase, the RAC1 gene, as a secondary mutation. And we built a model for that in the lab to study it. Sure enough, it would induce resistance to BRAF inhibition. So it's getting there.
So the TERT mutations are will probably be the worst prognostically.
Right.
What is their that?
So TERT promoter mutations in combination with BRAF or RAS does seem to be a much more important prognostic indicator. We don't yet have any therapeutic intervention that targets that abnormality, but because we think that the way that works is through a downstream mediator from BRAF inhibition that activates those mutations in TERT. The question is, with more effective inhibition of the MAP kinase pathway, can we prevent the TERT promoter from being an important contributor? So that's under study. We don't have clinical trials that specific to that. Most of the mutation profiling standard we've done does not include the TERT promoter very effectively either. It's relatively TERT point mutations are much more likely to be reported than TERT promoter, but that's not as relevant in pathway research.
You presented the anaplastic study, so what is the role of radiation in this study? So it doesn't see those patients that they're rapidly progressing, so to speak, give them the vaccine. So, but sometimes it's not enough. So do you incorporate radiation, and do you need to concurrently with vaccine? Do you continue as you put them on the study, or what's the?
Radiation is something that we do incorporate, but usually not upfront for these patients, unless they're ineligible, for systemic treatment. If they're about to get intubated because of airway collapse, we're going to have to do something different. And those are patients that we wouldn't want to give the anti-PD-L1 agent because oftentimes there's an early tumor expansion rather than shrinkage. So selection is important to them. But we are delaying radiation if we can, because at the end of the day, even those patients who respond initially to the local intervention kind of fail from distant disease. So we think systemic therapy is ultimately the more important agent.
I did learn a lot from your talk, but I do have one
slides on behalf of Alice and me. The first targeted therapy is actually prostate cancer. In 1941, androgen receptor, without knowing that it was androgen receptor, was treated with deprivation of the ligand. It is an American audience.
That's a good one. I'll have to change that.
It's rather awkward to follow that.
Oh, sorry.
So really, really beautiful. Appreciate it. I was curious, so thinking about the targets that these drugs are hitting, you described that Dabrafenib, Dabrafenib are primarily VEGF receptor inhibitors in terms of what they're doing in these patients. As you know, they get a lot of things, and including retina, as you also mentioned. With the newer generation of the clear drugs, granted they apparently have a little bit of activity, as you mentioned, on other things like VEGF. Are they showing similar activities? And if so, does that suggest that maybe Dabrafenib and Dabrafenib's primary targets are retina? In other words, what's your thinking behind VEGF receptors as primary target?
So, what I've counseled to companies is that they need to anticipate the opportunity to combine the drugs, because I don't think that red by itself will be sufficient. Without getting too much into confidential but still confidential information, there's definitely efficacy with the red selective agents. Will they be more effective or just less toxic? Is I think the question that needs to be addressed. We're just now getting to probably the highest dose levels in the dose finding components of these studies. So as they go into expansion cohorts and have a better sense of the efficacy, we'll get a lot more. But as you get up to the top dose levels, you begin to see hypertension and anti-VEGF type actions. So that's going to be good. Yeah. But the principle, Bob Gagel years ago did a study that unfortunately never got published because he never got an author's desk. But what they did was they used hammerhead ribosomes, and they eliminated the red RNA in the cell, and that was the end of the job. So these are probably still incompletely inhibited.
Thank you so much.
Good to see you again. Take care.
Hi, Alice. I do adrenal, and so I'd be very, very interested in, I can get your email, Perry, about what you're doing in metastatic PO and DTC.
Oh, absolutely. So,
Okay, because we run the adrenal center here, we have a multidisciplinary conference, and we never know what day we're going on. We just had our monthly meeting, and we had PO. We have a lot of adrenal patients now.
So for our field program, Camilla